So I'll try and be very brief. This past Monday, several of us from the Clinical Effectiveness Collaborative met with individuals at Lake Nona who are evolving a new healthcare system in Orlando, Florida. And we went there for the specific purpose, trying to see whether they wanted to be a model for a learning health system. It would be a test of the evolving strategy that has been promoted out of the Institute of Medicine and other places for a learning health system. As you're aware, the components of that include a digital infrastructure for data capture, focus on patient experience and the care quality, and a culture that aligns incentives to encourage that, and importantly, a commitment to research on care. And the conference that was held on large simple trials that identified a set of strategies that can be incorporated into health systems to continually improve research on care. And this conference, I think, will move us much closer to realizing the potential for clinical research to continually improve the practice of medicine and the outcomes for individual patients and the population more broadly. I don't have a lot to add to the recommendations and conclusions that we heard before, but just a couple of comments. It's not enough to document when there are conflicts among randomized trials and among observational studies or between them, nor is it enough to document when there are conflicts around treatment heterogeneity. We have an obligation in science to explain conflict, and we don't do enough of that. And I think the observational research would be advanced enormously if more attention was paid to really understanding sources of conflict in results both within observational studies as well as between observational studies and randomized trials. I would also say that if there's one set of themes that have come through very loud and clear to me, it is that we ask the right questions and collect the data that is suitable to answer those questions. I think PCORI is quite committed to ensuring that that is a high priority in their agenda as well. And finally, I hope that we will be expanding the scope of information that contributes to both observational research as well as clinical trials. We pay more attention to the patient experience, how we collect that experience and incorporate it to the environment in which they live, to the social and behavioral influences on their outcome, and to the biology that shapes ultimately their experience. I will conclude by telling you a very brief story that relates very much to my experience the last 2 days. You know, the story about the old man and a young boy who are taking a journey together and come to a village. And as they enter the village, the young boy is sitting on a donkey and the old man is walking beside him. And the villagers cry out in despair. How is it possible that this young boy is on the donkey and the old man is forced to walk? And so the old man has the boy get off the donkey, and he gets on the donkey, and they continue on their journey. And they come to the middle of the village, and the villagers cry out in despair. How is it possible that this old man is on the donkey and the young boy is forced to walk? And so the old man takes the boy and brings him onto the donkey with him. So now the donkey is carrying both the old man and the young boy. And they get to the end of the village to a bridge that they need to cross over a deep ravine. And the villagers cry out in despair. The old boy and the young man and the young boy and the old man are both on this donkey. How terrible for the donkey to have to carry the burden of both of these people. So the old man and the boy both get off of the donkey, and the old man puts the donkey on his back and carries him across the bridge. But the old man was old and weak, and the donkey was large and heavy. And by the time they got halfway across the bridge, he could no longer hold the donkey, and the donkey slid off his back and into the ravine. And the moral of the story, of course, is you can try to please all the people all the time, but if you do, you can kiss your ass goodbye. So I say that because we could not possibly imagine having had a conference that more directly, I think, addressed a set of very conflicting issues, but that resulted, I think, in a set of experiences within the conference that I think point a path to a very exciting agenda for research in observational studies. We haven't pleased all of you all the time, but I sense, Joe, that we've pleased enough of ourselves to really know where we can take this. I want to tell you how wonderful it is to be in an inspiring space like this, to have this conference, and to be among all of you to experience it. So thank you very much.
I'm going to pick up just where you left off, Ralph. First of all, though, I want to express my thanks to. This has been not only an enjoyable day and a half, but also I do think that we learned a lot, that PCORI learned a lot that we can take back and implement into our solicitations and into our thinking about research directions we want to take. I'm so glad that my colleagues David Hickam and Rachel Florence and Stanley Ip have been here with me for the duration, because I wouldn't trust my own ears and the mind connected to them to bring all of what's been said back. So thanks to the three of you. So I wanted to say just a bit about what we heard in the written comments from the tables yesterday. And in the process, I find I'm going to drift toward the future in the sense of toward that learning health system that we hope is the site of much of the comparative effectiveness research that's conducted in the next decade or so. So from these written comments, as well obviously from the live comments throughout the 2 days, calls for more data, more observations and more data per observation, better data, higher quality data, more complete and less missing data, more granular data, different types of data, like particularly data from the patient's perspective. And I think if you read our infrastructure announcements, which I really hope all of you do if you haven't started to take a look, these announcements, which are the product of a workshop led by the methodology committee about 10 months ago now, really in a number of ways point in that direction. But in the spirit of not kissing your ass goodbye prematurely, I'll also say that I came from a place where I would say researchers made their living for 50 years off of data that were collected for every purpose other than doing research. And every time there was an innovation in the data, the researchers were there to capture it in a heartbeat. Many of the later advances in the data and the move toward electronic health records were driven by reporting requirements. So we really do have to recognize the role of reporting requirements is and business considerations driving what winds up in the data as much as what the research community would like. And I'll get back to this in a minute, just to say that you know, with those poor data, the missing data, et cetera, my mentor, the person I learned most about epidemiology from, Gary Friedman, was a young postdoc or post research fellow. I don't know if they called them research fellows yet in those days, but after his internal medicine residency, he had wound up at Framingham and learned to do epidemiology, headed west, and very quickly, with some case control studies that relied solely on clinically delivered data and the forerunner of claims databases, I'd say hospital discharge data, constructed case control studies that replicated Framingham findings in African American patients, which Framingham clearly lacked, and in Asian American patients. So just, you know, the same risk factors. So those lousy data in short order generalized from very carefully collected cohort data. So, and over the years, I've seen enough cases where the data in the drawn from clinical practice replicates data drawn from either trials or replicates data drawn from very costly cohort studies. So I'm not ready to carry the donkey yet quite in that regard. I think that, that we can hold both in our minds at the same time, the need to ever be vigilant for problems with data, study empirically differences in data collected by one expensive route and data that are available to us because they've been accumulated in practice. So I really take the suggestions for empirical studies on the impact of differences in the quality of data on the and validations of studies found in one setting with studies found from other settings. Another comment from the tables yesterday was wherever you can, use randomized trials, use large simple trials, cluster randomized trials. And at our table, we got in then very quickly to talking about the issue of informed consent, number one, and whether it's always needed in cluster randomized trials. And number two, and maybe even more important, the consent of the sponsoring healthcare systems where these trials would go on. Does a healthcare system really want it known, and how does it prepare its members for the fact that they're randomizing treatments with or without informed consent? So, and I'll get back to that in a minute too. With respect to treatment effectiveness differences, really heard the call to think biology whenever possible, to think biomarkers, and I think that's really good advice when one can. Socioeconomic status factors equal importance, though. A lot of enthusiasm, as Rich said yesterday. The panel was sanguine about the utility of beginning to look more carefully for treatment and response differences. I think what we heard today that it is complex, however, and it's going to be, the progress may be slow in that area. I liked an idea that I heard that we really could benefit from one flagship model study that may be an adaptive trial, it may be some other design, probably would be a trial that looks, in fact, to predict individualized comparative effectiveness, to validate the findings from that, and then, of course, to work on presentation. How in the world do we present this data to not only patients but clinicians in ways that is useful and overcomes problems with numeracy and health literacy that research literacy that both suffer from. Then I want to say, just again, please examine, all of you, or as many of you who think you may conceivably be interested in our infrastructure announcements. In fact, examine them even if you don't think you'd be interested in applying, because if you don't think you'd be interested in applying for them, then we'd like to talk with you about them over the next several months. This is a very ambitious undertaking. It's an undertaking that PCORI is shouldering because PCORI has resources. It's an undertaking that everybody in DC appreciates is crucial, and we're going to need the insights of a group like this as we go forward. So back to the learning health system in closing. There isn't any doubt that if we want research that reflects real-world practice, and if we want research that changes real-world practice, the research is going to have to be done in that real world. And that real world is a variety of types of systems, some large integrated systems, some much more virtual systems. But among other things, it's going to take the active assent of those systems to host the research and to really allow the kinds of things that need to be done to conduct high-quality research to happen. So, and as I said, it does include communicating with the members so that the members don't begin leaving in droves, feeling like research subjects instead of patients. So, to the notion of what's PCORI's next workshop, it seems that there's a lot of learnings from this day that could be conveyed to an audience that had much more in the line of people representing health systems in the room. Some of the questions are, some of the questions for that conference are, what are the kinds of challenges, the kinds of research questions that you face? Systems are very often reluctant to undertake research. Zeroing in on the right questions, I think, is a part of it. Examples of research that has been conducted in systems and helped systems would be a big part of that. What are the data needs? Here, I think, is the chance to sort of marry the sensibilities of people in this room to what the data needs are and the lack with the concerns of those healthcare systems that we can only afford to collect that data which has clinical utility. So somehow heightening the appreciation for both the quality of the data and the kinds of data that are collected in the context of talking about how research could serve the systems. And lastly, certainly, what are the better methods for getting to those answers, and what about randomization within systems, and what about cluster randomization. So as you can see, I have been energized and stimulated by the conversation of the 2 days, as has my colleague Ralph, and so just add my thanks. And Michael, you have the closing word.